The term cellulitis is commonly used to indicate a non-necrotizing inflammation. Non-purulent cellulitis is associated with the 4 cardinal signs of infection, as follows: erythema, pain, swelling, warmth. The following findings suggest severe infection: malaise, chills, fever, and toxicity. Lymphangitic spread defined by red lines streaking away from the area of infection. Circumferential cellulitis. Pain disproportionate to examination findings. Indications for emergent surgical evaluation are as follows: violaceous bully, cutaneous hemorrhage, skin sloughing, skin anesthesia, rapid progression, gas in the tissue, hypertension. Generally, no workup is required in uncomplicated cases of cellulitis that meet the following criteria: limited area of involvement, minimal pain, no systemic signs of illness, like fever, altered mental status, tachypnea, tachycardia, and hypertension. No risk factors for serious illness, like extremes of age, general debility, and immunocompromise. The Infectious Disease Society of America recommends the following blood tests for patients with soft tissue infection who have signs and symptoms of systemic toxicity: blood cultures, CBC with differential, levels of creatinine, bicarbonate, creatine phosphokinase, and C-reactive protein. Blood cultures should also be done in the following circumstances: moderate to severe disease, like cellulitis complicating lymphedema, cellulitis of specific anatomic sites, like facial, especially ocular areas, patients with a history of contact with potentially contaminated water, patients with malignancy who are receiving chemotherapy, neutropenia or severe cell-mediated immunodeficiency, animal bites. Other studies to consider are as follows: mycologic investigations are advisable if recurrent episodes of cellulitis are suspected to be secondary to tinea pedis or onychomycosis. Ultrasonography may play a role in the detection of occult abscess and direction of care. If necrotizing fasciitis is a concern, CT imaging is typically used in stable patients. The Infectious Disease Society of America recommends considering inpatient admission in patients with hypertension and/or the following laboratories findings: elevated creatinine level, elevated creatine phosphokinase level, 2-3 times the upper limit of normal, C-reactive protein level, 13 mgl, low serum bicarbonate level, marked left shift on the CBC with differential. Treatment of cellulitis is as follows: antibiotic regimens are effective in more than 90% of patients. All but the smallest of abscesses require drainage for resolution, regardless of the pathogen. Drainage only, without antibiotics, may suffice if the abscess is relatively isolated, with little surrounding tissue involvement. Treatment of recurrent disease, usually related to venous or lymphatic obstruction, is as follows: the cellulitis is most often due to Streptococcus species. Daily amoxicillin or a macrolide may be effective for prevention of recurrences. If tinea pedis is suspected to be the predisposing cause, treat with topical or systemic antifungals. Patients with severe cellulitis require parenteral therapy. This video and all other my videos are used for teaching purposes only. Thank you for watching me. Please like, comment and subscribe to my channel. Bye until we meet again with another videos.